Good afternoon, everyone. iTech India welcomes all the participants for today's NDLS session. Today's topic is management of HIV positive pregnant women, and the speaker is Dr. Rohini Gupta. Dr. Rohini Gupta, ma'am, is a pediatrician with an MBBS and MD from Armed Forces Medical College, Pune. She has completed professional development courses from the University of Washington in leadership and management in health, implementation science, and clinical management of HIV. With over 35 years of extensive healthcare experience, she has served in Army Medical Services, led public health initiatives, and offered technical support for monitoring ART centers. Since 2009, uh, she has supported NACO in developing national guidelines, NACP training content for CST cadres and STI RTI medical officers, and treatment literacy materials. Her key contributions include formulating guidelines for HIV treatment, preventing mother to child transmission of HIV and syphilis, and strengthening HIV counseling and testing services. She is also a member of the NACO's Technical Resource Group for Pediatric ART. A note for the participants, requesting all the participants to please keep posting their questions in the chat box. All the questions will be taken up at the end of the session. We welcome you, ma'am, for today's session and request you to start the session.
Good afternoon, everyone. Uh, Welcome to the NDLS session today. Request, am I audible?
Yes, ma'am.
So I would like you all to keep answering the various questions that I've been putting up. I'll be asking in between. And I want it to be an interactive thing. So please keep answering in the chat box. And of course, any queries, please uh, put it up in the chat box and Shweta will share them later with us. So our session objectives for this session is that we will be discussing and will understand what is the risk of vertical transmission of HIV and how do you manage a HIV positive pregnant women. And our NDLS session is totally based on the national guidelines for elimination of vertical transmission of HIV and syphilis, September 2024. These guidelines, everybody should have a soft copy and refer to them. The relevant CST chapters are 6 and 7, but the previous chapters of prevention of HIV and syphilis is also important. So under the management of HIV positive pregnant women, we would be covering optimizing pregnancy outcomes in HIV positive women, care cascade for an HIV positive pregnant mother, management of women coming directly in labor, and ARV prophylaxis for HIV exposed babies. I'll be highlighting more points of the newer guidelines which are covered in this, and elimination of vertical transmission of HIV would be called EVTHS. So let's just have an overview of what is the status of EVTHS program in India as per Sankalak 6th edition 2024. So in the financial year 2023-24, there were 19,100 HIV positive pregnant women, a 63% increase over the last 2 years from 2020-21 to now 23-24. 92% of these women were provided EVTHS services. So there's still a gap of 8% of the identified pregnant women who are missing out on the EVTHS services. The important thing was that 593 women living with HIV were diagnosed with HIV in the postnatal period or during the breastfeeding period. That comes to 7.3 cases per 100 newly diagnosed pregnant women. This figure is very important. It highlights that we are missing out diagnosing cases during pregnancy, which are being diagnosed in the postnatal care period, or there are new infections occurring during the breastfeeding period. So maybe we need to monitor breastfeeding mothers for their adherence. They are missing out on being monitored for adherence because they are being taking 3 months, 6 medicines in proxy. So even if the mother is taking proxy, we have a system to assess their adherence. I'll be talking about it in the next few slides. In financial year 23-24, 97% of the identified pregnant women living with HIV were put on ART. Here also there's a gap of 3%. But one remarkable thing is that increase in the treatment coverage and identification of HIV positive mothers, the MTCT rate went down from 25% to 11.75% in 23. Let's see what does India HIV fact sheet 2025 says. The estimated need 18,470 women during the previous financial year, and the final MTCT rate has further reduced to 10.25. But is this adequate? Our aim is elimination. Elimination means that the MTCT rate should come down to zero. So we need to implement each and every guideline which we are going to be discussing in total, and monitoring of a pregnant woman with HIV is very important, because that is where we will help in eliminating and making the MTCT rate zero. So just an overview, everybody knows this chart. They know what is this. The important things is that vertical transmission or mother to child transmission. Now we don't say it as mother to child. We talk about vertical transmission. Occurs during pregnancy, childbirth, and during breastfeeding period. The highest risk of HIV transmission is during childbirth. And this risk is covered by the ARV prophylaxis, which we give to the baby. That's 6 weeks of minimum ARV prophylaxis given to a baby born to an HIV positive mother covers the HIV exposure during childbirth. The risk of HIV transmission solely is based on the HIV viral load in the mother. So it's very important to ensure HIV viral suppression during pre-pregnancy. That means they should plan their pregnancy while they are virally suppressed. During pregnancy, throughout their breastfeeding period, this actually reduces the risk of vertical transmission. And those on breastfeeding, the risk of vertical transmission with all the interventions of EVTHS is 2%, while if the mother says that I'll be taking replacement feeding, it is 1%. There's only a 1% difference. But the important thing is that if the mother is having undetectable viral load, so all the secretions will have no virus available, and hence the risk of transmission becomes negligible. That is what we need to ensure, that our pregnant women are on ART adherent with negligible risk, and that will occur if we are going to be having pregnant women with HIV with undetectable viral loads from pre-pregnancy, pregnancy through breastfeeding period, and actually lifelong. That is the important thing. So there are a lot of factors. Everybody has looked at these detailed charts. I'll just tell you the 5 important maternal factors. These 5 important are very important because this is where the ART staff is should be careful. So recent HIV infection in the mother, high viral load, resistant strains, advanced HIV disease, and concurrent STIs. So these are the factors which really increase the risk of the baby getting HIV. And that is why we say that mother should be adherent on ART, should practice safer sex practices and use condoms, because that will prevent new HIV infection and STIs. STIs, RTIs always increase the risk of vertical transmission of HIV to the baby. There are various obstetric factors. This we will cover as how to prevent them while we are during childbirth. And the infant factors, of course, everybody knows that the preterm baby, a low birth weight baby, twins, the first of a twins, mouth sores, all these increase the risk of HIV transmission to the baby. So what are the steps which we can take to reduce? So during pregnancy, ART reduces the risk. Ensure ART adherence and viral suppression. Advise safer sex practices and condom uses to reduce risk of HIV reinfection and STI RTIs, because this will increase. Institutional delivery during childbirth is very important. Ensure precautions For mother and baby during childbirth, you can immediately start the baby on ARV prophylaxis, which will be available. So birth planning is very important, and this is part of the counseling which you need to be think. And the ARV prophylaxis is started within 2 hours, ideally within 2 hours, though we can even give it, it's effective even up to 72 hours. But anytime the mother comes, even if she comes late, the baby should be given ARV prophylaxis. During breastfeeding, if mother is adherent on ART, virally suppressed, U is equal to U, it will cover the uh, risk, it will prevent the risk of HIV transmission through breast milk, because mother is an ART and is virally suppressed. But if the mother is virally unsuppressed, then we give an extended duration of ARV prophylaxis from 6 weeks to 12 weeks, during which time we cover the exposure through breast milk and hope that the TLD which the mother is taking will kick in, will start affecting, and mother becomes virally suppressed. And that further reduces the risk of breastfeeding. So the whole total game is viral suppression, adherence to ART, and the third is prevention, safer sex practices, and prevention of uh, uh, STIs, RTIs, and institutional delivery. So let's just go ahead. So what is optimizing pregnancy outcomes in HIV positive women? This is actually a programmatic approach where we have planned few interventions, which are, this is new. So there is something called an extended uh, PMS, extended PMSMA, which is Pradhan Mantri Surakshit Matritva Abhiyan. And the extended PMSMA is given to all high-risk pregnancies and women with HIV, with syphilis or hepatitis B, all these infections. The pregnant mother comes under the high-risk pregnancy bracket, and they'll be given three additional antenatal checkups. Birth planning, very important, where you need to identify the place of delivery. The counselor from the ART center and the ICTC both can find out where is the place which is near to the lady where she'll be delivering. Contact the person there, contact the ICTC counselor there and inform. So birth planning is very important, and information about care during antenatal period, childbirth, postnatal period, any danger signs, inform her about the expected date of delivery, identify the place of delivery, and it's very important to inform them and the spouse that you need to carry your ART green book, because all the entries of the viral load and what prophylaxis to be given, the latest viral load report is all given in the green book. So that will help in the baby being started on the ARV prophylaxis within 2 hours of delivery. Institutional delivery, so linkage to the nearest first referral unit. This can be near where the mother stays. The ANM and ASHA will support this activity with confidentiality. Pre-sensitization of a delivery site that, okay, we have a high-risk pregnancy mother who will be delivering at your site, and delivery will be at a CMOC facility, which is Comprehensive Emergency Obstetric and Newborn Care, where a pediatrician or gynecologist are all there, and they are all having all the facilities to look after high risk pregnancy deliver. This is very important. Outreach and patient tracking. So prioritize tracking of pregnant women living with HIV for adherence, viral load suppression, and ARV prophylaxis prescriptions prior. So if the mother has undergone a viral load, what drugs the baby should get will be written in the green book by the medical officer. And this tracking, because maybe the mother is pregnant and not able to come, but the tracking will be done by the CSC. This tracking is very important. Postnatally also is very important, because the mother needs to be adherent during her breastfeeding period also. So how does ART work? We all know ART works in it improves the maternal health. It prevents HIV replication in the baby. The ARVs also enter the baby through the placenta, and if by chance few HIV viruses have entered from the mother through the placenta, these ARVs will prevent the baby getting infected. Reduces maternal viral load. by reducing the maternal viral load and achieving viral suppression, if it is undetectable viral load, then the virus has actually gone and migrated out from the secretions and blood into various organs, and she has achieved what is called undetectable viral load is untransmittable HIV. That is, the risk of HIV transmission with undetectable viral load becomes negligible, and this reduces the risk of HIV transmission to a very low risk. DTG-based ART regimens is the national guideline. All pregnant women should be started. So all pregnant women, whether HIV, HIV-1, 2, HIV-2, past history of a single dose nevirapine in the previous pregnancies, pregnant mothers with TB, hepatitis, all HIV, TB and co-infection, HIV, hepatitis, all these women, the TLD will work. Now, what is the advantage of dolutegravir, which is there in this combination? Causes a very fast viral suppression. Can you put down in your chat box how fast is the viral suppression once a patient or once a pregnant woman is started on TLD or a dolutegravir based ART regimen? Just put in your chat box how much time does it take to cause viral suppression. Any more answers? What is the earliest? I've got 4 weeks. So the earliest the viral suppression occurs is 15 days, 14 days, 2 weeks. The earliest it happens is 2 weeks, and most of them get virally suppressed if they are adherent to TLD within 4 weeks. Some with a very high viral load may take 6 weeks, but the fastest it occurs is at 14 days. So that is why TLD is advised in all pregnant women. Those who were already on TLD need to continue the regimen. They should be explained because of the quick viral suppression. We want to achieve undetectable viral loads. Now, all women who are not receiving DTG-based ART regimen need to be transitioned. But if the lady has failed on DTG or has been given exposed to DTG previously and there's a documented failure, then this pregnant women should be referred to SASEP to take an expert opinion about what regimen would be suitable for her, which will help in reducing the vertical transmission to the baby. So what are the other alternate regimens? Instead of tenofovir, we'll need to give abacavir, lamivudine, dolutegravir if the weight is less than 30 kgs. If the woman has high serum creatinine level, then ALD will be given as separate tablets, and the dose of lamivudine will be titrated as per the creatinine clearance. You need to take opinion from SASEP. If the lady's got TB, HIV co-infection on a rifampicin-based ATT regimen, then we need to give an additional dose of DTG 50 milligrams after 12 hours from TLD, and this will continue for 2 weeks after completion of ATT, because there's interaction between rifampicin and dolutegravir. Rifampicin reduces the blood levels of dolutegravir, and with rifampicin based ATT, you need to give an additional dose of DTG after 12 hours. So it will be TLD plus DTG. The important thing is, if the lady's got drug resistant TB, then you do not need to give an additional dose of dolutegravir, because there is no rifampicin in the drug resistant TB treatment. These are the side effects everybody knows, but the one marked in yellow is very important. There are a lot of interactions between aluminum, calcium, iron, magnesium, zinc, antacids, multivitamins. So all pregnant women will be on iron, calcium supplements, and maybe advised pantoprazole and other things. So you must make sure that DTG has to be given 2 hours before these medicines or 6 hours after these medicines. This is very important. Sometimes it happens is that there's no viral suppression, and later we come to know that she's been taking DTG along with her calcium tablets, which is wrong. So this is very important that you need to time her medicines, her supplements, and this is the responsibility of the counselor, who needs to sit down with the pregnant lady and ask her, what time will you take the ART, what time will you take your iron, what time will you take your, if the mother is on cotrimoxazole, what time will you take that, and what time will you take your calcium. So this is just a recap. So we do fast track investigations, counsel for importance of ART, ART adherence, importance of U is equal to U, and safer sex practice. You must tell them that if you have undetectable viral loads, the risk of baby getting is, you must explain in the local language what is U is equal to U. The ART regimen for newly diagnosed HIV positive women is TLD. Rapid ART initiation defined as within 7 days, preferably in pregnant women. It should be on the same day unless she has some OI or some other issues, chronic systemic infection or disease underlying. So in that case, you may delay it, but preferably if the mother is stable, counseled, and prepared, it should be a same day ART initiation. Remember, the timing is important. Antacids, multivitamins, and supplements use DTG 2 hours before or 6 hours after these things. So basically, you inform that there should be a 6 hours gap between each and every medicine you're taking. Telephonically contact within 2 weeks of ART initiation, inquire about drug adherence, any adverse effects, and it's the responsibility of the lab technician and the counselor. They both should see what are the lab reports, inform the SMO, and if the creatinine is raised or any of the lab reports are abnormal, you have to immediately call back the person, the pregnant women, to the center, and in this you can take help from the CSC. Most important adverse effects which occur is nausea and vomiting. So adjust the pill timing. You can take DTG with or without food. There is no interaction with food and DTG and TLD, but you must explain to them how to take the medicine, rule out other causes of vomiting like jaundice or hepatitis or some infection, GI infection or a respiratory infection, and safe antiemetics after consulting the gynecologist may be given. So all the monitoring and follow-up of a pregnant women is the same, except it's the same as non-pregnant women. The only difference is there's a viral load testing, additional viral load testing, which is to be done at 32 to 36 weeks. How is this viral load different from the routine viral load? Routine viral load, we see whether the ART has taken action and what viral suppression has happened. This viral load, which we do in the last month of pregnancy or the last 4 weeks of pregnancy, is that to know whether the baby is high risk for HIV transmission and low risk for HIV transmission, and what are the drugs which need to be given to the baby to prevent vertical transmission of HIV. So all pregnant women with HIV need to undergo an additional viral load test between 32 to 36 weeks. In simple words, the last month of pregnancy, you need to inform them and the spouse, and it's very important that they come to give their viral load test during that time, and the spouse is counseled that please come to pick up the report, because it's very important that the report is entered in the green book, and the ARV drugs which the baby should get after delivery should be written in the green book, because the delivery may not happen in the same place, where in the same institute where the ART center is. Maybe the delivery is happening somewhere near where the person, the pregnant woman is staying. So it is important that all this is endorsed, and they should be counseled that it has to be a birth planning planned where the mother is going to deliver, and this green book needs to be carried. Now, the important thing is, irrespective of duration of ART, please do not mix the dates of viral load testing at 32 to 36 weeks with the viral load testing, which is the routine viral load testing. Even if it has been done at 3 months, that is for viral suppression. This is a viral load test done in the last month of pregnancy to see whether mother is virally suppressed. If the mother has got a VL of less than 1,000 copies, then the baby will be categorized as low risk for HIV transmission, and such babies will be advised a single ARV drug for 6 weeks, irrespective of all the feed, whatever feeding option. Reason is that mother is virally suppressed and the baby is at low risk for transmission of HIV. But my babies whose mother's viral load is more than 1,000 copies, more than and equal to, or with no viral load, or diagnosed direct in labor or diagnosed postnatally, they all will be categorized as high risk for HIV transmission, and all babies, high risk babies, will be advised dual ARV prophylaxis, and the duration will depend on the feeding option. So what are the measures to be taken by the ART team? One is that first thing is that counsel the importance of viral load, and it's like an reinforcement. The mother, the spouse, and the pregnant lady, they should be reinforced at each place she goes. So if she comes to the counselor should inform that this is the thing. When do you want us to put it? What would be the convenient day you would like to come? And the pill pickup could also be on the same day the viral load is done. Okay, the same thing can be reinforced by the staff nurse, the same thing can be reinforced by the medical officer, and the lab technician will ensure that the date of the viral load test is pre-planned and it matches the pickup date. It's not an extra date, a separate date from the pill pickup date. Record the viral load test date in the patient booklet, white card, and the guidelines say in the MCH card also, because they should know, the gynecologist should know that, okay, the viral load test is due on this, and the next visit they will ask what is the viral load result. Data manager is supposed to generate a line list of all HIV positive pregnant women in that center which are due for their viral load test 32 to 36 weeks in that month. So on first or second of each month, the data manager is supposed to generate a line list, inform all the staff members, counselor, staff nurse, SMO, and the lab technician, so that there's coordination about giving counseling, giving the date for viral load testing. The counselor should contact or remind the pregnant lady and the or her spouse at least 15 days before the viral load due date. Certain women go to their villages, so they are not available at the center where they are going to be doing it. So then the counselor needs to tell this lady that, okay, when are you going? Either do your viral load before you leave, or if you're going to be going before the viral load test, then the viral load testing has to be actually organized. So the ideal thing is that we should be telling them about the viral load test to be done in the same ART center, and wherever they are going, that ART center, the nearest co-located ART center, can be informed about the viral load result. So the important of birth planning also important is whether she's going to her maternal place or not. So there's a lot of coordination which the ART team along with the ICTC counselor, because the ICTC counselor will be contacting the ICTC counselor at the birth planning center delivery site. So these are very important things and they should be done timely. MO will enter the viral load test results, the HIV risk categorization, and the drugs for ARV prophylaxis in the ART patient booklet. It will only be the drugs. The dosage will be after the baby is born based on the weight. And the drug dosage charts have already been given. And there's usually in the CMOC, the comprehensive facilities, the CMOC facilities have a pediatrician, and the pediatrician is aware about the doses of the ARV prophylaxis which needs to be given. But it has to be entered, and the mother has to carry the ART patient booklet with her for her delivery. Parents are to be explained about the VL result, explain that a medicine has to be started for the baby immediately after birth. You need to take the ART patient booklet along with you. You need to finalize what is the birth site, birth planning. This is very important. So these are very important things where we will not lose, the mother will not lose out on the EVTHS services. So there is an EVTHS card, section 11 of the patient treatment card, which needs to be filled up. And this is a part of the new white card, which is available at the ART center. And this card, for each pregnancy, it has to be a fresh insert, because this includes the HIV exposed infant, and it ends with when the breastfeeding. So all the particulars for that pregnancy, the delivery dates, the birth date, the ARV prophylaxis in the baby, everything. So in the next pregnancy, another insert would need to be done. Now, what are the counseling messages which are very important, which need to be reinforced at every visit? One is explain the advantages of ART for our health and prevent vertical transmission, and need for starting ART immediately if newly diagnosed. Adherence to ART during pregnancy, labor, entire breastfeeding period, and lifelong for her health, and to prevent transmission, vertical transmission. Safer sex practices to avoid fresh HIV and STI infection throughout pregnancy. Don't forget the breastfeeding period. It is the breastfeeding period which we are neglecting. So it's very important that we counsel these counseling messages through the breastfeeding period. Counsel for regular ANC visits, antenatal counseling for selecting feeding options by parents. Care of nipple and breast should start in the antenatal period. Nutritional counseling for the mother to aimed at a balanced diet. Iron, folic acid, calcium supplements are to be advised throughout pregnancy and throughout the breastfeeding period. Important that its timing should be fixed as per what we have said about the guidelines, that there has to be a 6 hours difference from the ART, TLD, and these supplements. Viral load testing at 32 to 36 weeks of gestation to decide the risk of HIV transmission to the baby. Institutional delivery and birth planning for interventions during childbirth and timely initiation of ARV prophylaxis. ARV prophylaxis to be started to the baby immediately after birth, and all this will be available once the birth planning is there, and there's already an information given to the birth site that we have this patient and the due date is this. The information and counseling should be given about that the baby will be under follow-up till the HIV infection is excluded, 18 months or 3 months after stopping breastfeeding. So just delivery is not the end point. The baby and the mother of course will be followed up lifelong, but the baby will need to be followed up till the baby is continuing breastfeeding and till HIV infection is excluded. So what are the various interventions to reduce HIV during pregnancy? We need to provide information about HIV to all pregnant women. Antenatal visits, you should be doing the HIV and syphilis testing. You need to counsel for safer sex practices to avoid fresh HIV and STI infections. Adherent ART to prevent vertical transmission. Viral load testing between 32 to 36 weeks of pregnancy to determine what ARV prophylaxis is to be given to the baby. Counseling for institutional delivery and birth planning. Counseling on infant feeding practices and ARV prophylaxis and safe obstetric practices is very important. So what are the interventions to reduce risk of HIV during childbirth, and why we are saying it is important that we have birth planning and the delivery site is identified? Because these are the precautions which, if taken, will institutional delivery will reduce the risk, because the maximum risk of HIV transmission is during childbirth, as I had said. So under the cover of maternal ART, the care given to HIV positive mothers and their babies is a similar care given to uninfected mothers and their babies. When delivering HIV positive, safe delivery techniques like standard work precautions is everybody does it, but it's mentioned because we need to be ensure that it should be in place. Minimize vaginal infection examinations and use aseptic techniques. Avoid prolonged labor. Consider oxytocin to shorten the labor. Avoid artificial rupture of membranes. Use non-invasive fetal monitoring. Support perineum and avoid routine episiotomy. If episiotomy is really necessary, then a small episiotomy is to be given, and avoid instrumental delivery as much as possible unless indicated. It is that instrumental delivery increases the risk of vertical transmission or transmission of HIV during childbirth. But remember that if the mother has undetectable viral loads, the virus has come out from the blood and the secretions and gone and lodged in various reservoirs like the brain and the spleen and the lymph nodes. So the secretions will not have so much, will have negligible to zero amount of viruses in the thing. So the important thing is that the mother should have undetectable viral load. That helps in reducing the risk during pregnancy, childbirth, especially. Now, mode of delivery in India, normal vaginal delivery is considered unless the mother has obstetric indications, whereas cesarean, like fetal distress or obstructed labor. Remember that previously for HIV, a planned cesarean was done. Now, HIV is not an indication for a planned cesarean. There is no need for a planned cesarean because the mother is on ART, virally suppressed. Even if it is not virally suppressed, we have taken precautions where we will reduce the risk, and the baby will be put, if the baby's mother's viral load is high, the baby will be put on dual prophylaxis to cover whatever the risk of HIV has occurred during childbirth. That is why it is important to know what is the viral load in the mother before childbirth in the last trimester, because that will tell us what is the risk during childbirth for exposure to the baby. So what are the interventions for a pregnant woman coming directly in labor? There is a little change in the guidelines, so request you to please be a little attentive. So as usual, labor room will offer bedside counseling and HIV screening test. The two is if the women consent, so even there a consent will be requested, and screening for HIV either by a point of care finger prick test, whole blood finger prick test, or dual RTT kits where both HIV and syphilis are used. If the result is screen reactive for HIV, the labor room nurse will inform the ICTC counsel NT lab technician for confirmation of HIV status as per guidelines. And only if the mother is HIV positive confirmed, that the lady will be linked to ART services and initiated on ART at the earliest. So these are, this is a change in the guideline from the 2021 guidelines. So please be clear about this. The ART will be given only by the ART center once the mother is linked to the ART services after the HIV positive status is confirmed. So this is the cascade. Is it visible? I would request you all to print out this. This is in figure 6.2.1, the care cascade, and keep it on your table because this is very important. It's a gist of the whole EBTHS thing, how we look after our pregnant women. So if at the screening side during ANC, she becomes HIV positive, there's a confirmation at the ICTC. If she is HIV positive, registration at ART center, preparedness counseling, baseline investigations, clinical evaluation by medical officer, and rapid ART initiation. What is Suman? Surakshit Matritva Ashwasan Scheme. All pregnant women who should be given following services at the ART center. So counseling for ART adherence, safe sex practice, viral load testing at 32 to 36 weeks of irrespective of ART duration. This is 32 to 36 weeks of pregnancy gestation. Risk assessment of baby based on what is the mother's viral load. Prescription of the ARV prophylaxis by the medical officer and documented. It will be only what are the drugs to be given based on high risk or low risk. Treatment to be provided at the DSRC or a general health facility for syphilis, or if co-infection with syphilis or STI infection, it's very important to be treated for that, because that STI or syphilis will increase the risk of HIV transmission to the baby. High risk pregnancy should case under the PMSMA, which I explained, and ensure pre-sensitization of delivery site in institutional delivery to be conducted at CMOC. CMOC is Comprehensive Emergency Obstetric and Newborn Care. Now, what if the mother comes directly in labor? So she'll be screened for HIV in the labor room. If HIV is screened reactive, then the uh, lab technician and the counselor from the ICTC will confirm the HIV infection. If HIV is confirmed, the baby will be initiated on dual ARV prophylaxis by the labor room or maternity ward medical officer after consultation with the co-located ART-MO. The reason is that it has to be a prescription by a medical officer or a pediatrician. And if they are not aware about what ARV prophylaxis, then the ICTC counselor will connect them with the co-located ART-MO or the nearest ART-MO, and they will be able to help them out in making a prescription of dual ARV prophylaxis, and what is going to be the dosage to be given to the baby. So it has to be a prescription by the labor room or maternity ward medical officer, and help can be taken, or a consultation, telephonic consultation can be done, facilitated by the ICTC counselor with the co-located or nearest ART center medical officer. So if mother is HIV positive, then the lady will be postpartum, will be immediately linked to the ART center or the link ART center and registered, and ART preparedness counseling is done, baseline investigation, evaluation, rapid ART initiation, and the others are the same. The prescription of the ARV prophylaxis will be continued by the medical officer, or it will be endorsed in the green book, so that the ARV prophylaxis given will be endorsed in the green book, so that it can be continued for whatever duration. If it's breastfeeding, then for 12 weeks. If replacement feeding, then for 6 weeks, the baby will be given. Care of pregnant women with HIV and syphilis co-infection. So when you have both HIV and syphilis, as I said, there's an increased risk of vertical transmission to the baby. If the placenta is inflamed due to syphilis, there's increased risk of HIV passing through the infected placenta. If a pregnant woman with HIV screens positive for syphilis or has signs of syphilis, treatment should be given even if the test is negative or it is unclear or has clinical signs. So any pregnant lady with HIV has syphilis, comes out syphilis positive, will be treated with 3 doses of penicillin, once a week over 3 weeks. And even if the mother has clinical signs of syphilis or has unclear results, benefit should be given so that it can prevent mother to child transmission of syphilis, and you can take an opinion from the DSRC in where there is unclear results, or the test comes negative but the mother has clinical signs of syphilis. Repeat testing is to be done 3 months after treatment, and a repeat also in the 3rd trimester and at labor, to see whether she has responded to the thing or if there's a reinfection. So all mothers who are treated for syphilis would need a syphilis testing for syphilis at during labor, and a regular follow-up at the DSRC for up to 2 years. Her baby would be referred to the NICU or a pediatric treatment facility soon after birth for evaluation, and RPR VDRL tests of baby and mother at birth from the same lab will be seen, and if the baby's titer is 4 times that of the mother, then the baby will be treated. The guidelines are given in the EBTHS guidelines. You can further have a look, but this will be done by the pediatrician at the pediatric treatment facility. The medical officers at the ART center have to ensure that the baby is followed up at the pediatric treatment center, are referred immediately after birth there, and are treated. Her baby is to be kept under follow-up up till 6 months or more, depending on what is the treatment status of the mother. So what are the feeding options? The feeding options to be discussed in the antenatal period, and there are 3 feeding options. One is exclusive breastfeeding. I think everybody knows about this. I would not go in detail. The only thing is that mixed feeding means in the first 6 months of life, you give something along with breastfeeding. But beyond 6 months of life, this is not called mixed feeding. We are saying that after 6 months of age, the baby should be started on complementary feeding. So what is our advantages of EBF versus replacement feeding? So all the blues are the benefits, and the disadvantage in breastfeeding, exclusive breastfeeding, is risk of baby acquiring HIV infection. But remember, it's negligible if the mother has undetectable viral load, because the virus is not there in the breast milk to cause infection. The HIV virus has migrated to the various um, uh, organs and is sleeping there. So it is very important and safe to breastfeed if the mother has suppressed viral loads and ideally undetectable viral loads. Replacement feeding have a lot of disadvantages, which we already know. This is just a revision about it. So what are our national guidelines? Exclusive breastfeeding for 6 months, introduce complementary feeding at 6 months, continue breastfeeding for 12 to 24 months as for general population, ensure that she has good adherence, a suppressed maternal viral load, and safer sex practices throughout her breastfeeding to avoid reinfection with a new HIV strain or STI RTIs, which will again increase the risk of baby getting HIV through breast milk. So these are important things. Exclusive replacement feeding is considered only in situations where breastfeeding cannot be done, that is maternal death, severe maternal illness, mother is on certain drugs which will get secreted in the breast milk, or mother has something like anti-epileptics and warfarin and things where mother cannot breastfeed, or in a very small proportion where the parents are insisting. But remember that in adherent ART, where mother is has viral suppression, breast milk is made safe by giving ART to the mother and ARV prophylaxis to the baby. Exclusive replacement feeding is only recommended if all 6 criteria of ERF are met. We all know about these criteria. And immediate care at birth. So what are the do's? Wipe the mouth and nostril as soon as the baby is delivered, so that all the secretions are wiped off. When you clamp the cord, it should be done soon after birth, and you should cover it with a gauze so that there is less spillage of blood. uh, Breastfeeding should be initiated in the first hour of birth. What are the don'ts? Avoid multiple vaginal examinations, avoid invasive fetal monitoring, avoid suction. If you must, then do it with a bulb. Where the suction is less than 100 millimeters of mercury pressure. Avoid milking of cord. Under the cover of maternal ART, there is no difference in the care given at birth and is similar given to HIV negative mothers and their babies. Most important is universal precautions for all healthcare providers. Now, ARV prophylaxis to the babies. So, we have two kinds of situations based on the mother's viral load. So, if the mother's viral load is suppressed, the babies born to these mothers have a low risk of HIV transmission, will be given a single drug for 6 weeks, both breastfed and exclusively replacement fed babies. High risk for HIV transmission are those babies born to mothers with viral load more than equal to 1,000 copies, viral load test not done, not initiated on ART, HIV diagnosed postnatally within 6 weeks. Now, if the mother is breastfeeding because she is unsuppressed, 2 drugs will be given because it's high risk and will continue for 12 weeks, 6 weeks to cover the exposure during childbirth, and the next 6 weeks to cover the exposure through breast milk. So hoping, because the mother will be initiated on ART, or if she is already on ART adherence will be ensured, so that in the next 12 weeks, the TLD has started working and the mother has achieved viral suppression by the time the 12 weeks complete. If the baby is high risk for transmission and the mother has said, no, I want to give replacement feeding, then only 2 drugs are given for 6 weeks, because we need to only cover the exposure during childbirth. The NACP counselor at the ICTC will ensure responsibility that the baby will get ARV prophylaxis, preferably within 1 hour of delivery, which is possible if a birth planning is done and there is coordination between the ART, ICTC, and the delivery site. The ARV prophylaxis drugs will be mobilized by the NACP counselor at the ICTC at the delivery site. ARV prophylaxis can be started beyond 72 hours, but its efficacy will be reduced. But we need to give a chance to all babies whenever the first contact. This actually happens when the mother is diagnosed postnatally. So whenever the mother comes in first contact with the health facility, once she comes to know about a HIV positive status, the baby should be given ARV prophylaxis. The ART-MO will enter the viral load report. All this has already been covered in the previous thing. It is just reinforcing that the ART-MO should put all the details in the green book. Duration I've already explained. So those with low risk would be 6 weeks. Those with high risk, breastfeeding would be 12 weeks. Replacement feeding would be 6 weeks, because 12 weeks is extended so that the TLD kicks in, causes viral suppression, and the breast milk becomes safe under the ART which the mother is taking. So what are the drugs in low risk? It either nevirapine or zidovudine. So in certain situations where nevirapine will not be effective, zidovudine will be given as a single drug. And these situations are if the mother is HIV-2 has HIV-2 infection, has HIV-1 and 2 combined infections, or the infant is born to a mother who has history of receiving nevirapine in the previous pregnancy or delivery. The reason is that she would be having archive nevirapine resistant strains, and the same would pass over to the baby, and nevirapine would not be effective in such a situation. In those situations, syrup zidovudine will be given. And infants born to mothers who are on PI based ART regimen due to treatment failure, we assume that the mother has resistant strains to nevirapine, and hence zidovudine would be given to this baby. So there are 3 indications where nevirapine will not work and zidovudine will be given. So zidovudine has to be given twice a day. Nevirapine has to be given once a day. For high-risk infants, so high-risk infants, the situations I've already explained. These are the 4 situations where you will be giving, the baby would be high-risk for HIV transmission, and a combination of 2 drugs, syrup nevirapine given once a day, syrup zidovudine given twice a day would need to be given. And for 6 weeks, if replacement feeding mother is doing, and for 12 weeks if it's exclusive breastfeeding. Certain scenarios where the HIV-2 positive mother with high risk pregnancy, they would need to take SASEP opinion. Now, the aim is that we need to have mothers with viral suppression so that the babies are all low risk for HIV transmission, and a single drug ARV prophylaxis is to be given. Most of them should be like this. Now, already in the care cassette, we have covered that mothers who come direct in labor, their babies are high-risk infant, and dual prophylaxis, nevirapine and zidovudine would be advised. And as we said, the medical officer of the labor room ward would telephonically consult the medical officer, the co-located ART, regarding the dosage of these 2 drugs based on the weight of the baby. And the NACP counselor of that ICTC, which is at that center where the labor room is, will be ensure that the baby gets ARV prophylaxis at the earliest. What about those women who come newly identified postnatally within 6 weeks of delivery? They too will be, their baby too will be high risk for HIV transmission. These are those 593 cases. These are those women who were diagnosed after delivery of the baby. And so any mother who's diagnosed HIV positive within 6 weeks from her delivery would, the baby would be given ARV prophylaxis, and the baby would be a high risk for HIV transmission and would need to be given dual drug ARV prophylaxis. That is nevirapine once a day, zidovudine twice a day. And the mother needs to be started on ART. And the duration would be, if breastfeeding, 12 weeks, the 2 drugs. If mother is taking replacement feeding, then 6 weeks of dual drugs. Now, these are the dosage. We have already shared the annexure 7 from the EVTHS guidelines. I hope you all had that as a handout, because we'll be going through various case scenarios. That is the last part of my session. So just, I would like you all to type in your chat box, infant born to HIV positive mother, not an ART, what is the status? Fast. What is the risks? Okay, very good. Maternal viral load not done between 32 weeks of pregnancy till delivery. What would it be? What is the risk? High risk. Very good. The next situation, unsuppressed maternal load between 32 weeks to 36 weeks of pregnancy. High risk. Mother newly diagnosed HIV positive within 6 weeks of delivery, including direct in labor cases, the baby would be high risk. And last, infant born to a mother with suppressed viral load at 32 to 36 weeks, that is TND, target not detected or undetectable viral load, or a viral load less than 1,000 copies, would be low risk. So the answer is high risk for everything. The low risk is only this situation. Our aim is to have all our pregnant women who are diagnosed with HIV to have this situation, the yellow situation, and the least few, very few should be high risk. So let's have you all answering. Mrs. A in 2012 during her first pregnancy received a single dose nevirapine. Now she has come with 4 months of pregnancy. Her CD4 is 420. What ART regimen should be advised? ART would be TLD. Why? Because TLD works for all situations. Now she's undergone a viral load report at 34 weeks. VL is 500 copies per ml. She plans to breastfeed the baby. What ARV prophylaxis should be advised and what duration? So let's see your answers. Yes, TLD. Now I need the answer for the okay. The TLD for 6 weeks. Okay. Yes, zidovudine for 6 weeks. Why zidovudine? Because the mother was given, the mother is low, 500 copies, baby is low risk for ARV, for HIV transmission, single drug, but it is syrup zidovudine twice a day for 6 weeks, because she has had, the mother has had a single dose nevirapine in the past. So it is not, nevirapine cannot be given in this situation. Please remember, nevirapine, the baby would be having archived NRTI resistant strains transmitted from the mother. Nevirapine will not work. So in this situation, syrup zidovudine will be given, and it will be 6 weeks irrespective of type of feeding, because it's low risk for infant. Next scenario. Mrs. B is 26 years, was registered in 2016. She was initiated at TLE. She became lost to follow-up. Now she's reported with a history of 3 months of pregnancy. How will you manage this patient? We would be starting ART immediately. What is the drug? TLD. Very good. So it has to be a DTG-based regimen, 1 tablet once a day. Now the mother's report at 36 weeks of gestation was 900 copies. What infant prophylaxis should be advised? Please type in your chat box. Very happy to see nevirapine 6 weeks, but some people have written dual prophylaxis. Dual prophylaxis won't be indicated here because the viral load is less than 1,000 copies. Because it is less than 1,000 copies, the baby becomes low risk for HIV transmission. Single drug for ARV prophylaxis, because the mother was not been exposed to nevirapine in the past, was on TLE. Single dose nevirapine in the past, not a triple drug regimen in the past. It's a single dose nevirapine which causes nevirapine resistant strains. Okay, so in this case scenario, the syrup nevirapine once a day for 6 weeks is the answer. So case scenario 3, a pregnant lady, 4 months, CD4 420, what ART regimen? So it has to be TLD once a day. Now the viral load report is 1,500 copies. She plans to breastfeed. What infant prophylaxis and how long duration? Please let's have. Very good. Dual prophylaxis. Very good. So the answer is dual prophylaxis. Syrup nevirapine once a day, syrup zidovudine twice a day, to be given for 12 weeks. Very good. I'm very happy all of you all have understood. So it has to be 12 weeks because the mother's viral load is more than 1,000 copies. The baby becomes high risk infant for HIV transmission. The baby has to be given 2 drugs, nevirapine and zidovudine, because the mother's viral suppression is not there. 6 weeks is given for the exposure at childbirth. The next 6 weeks are given to cover the breastfeeding period, hoping that by 12 weeks the mother would have become, because she's on TLD where the ART will work and viral suppression occurs within 4 weeks of starting. So in this scenario, by 12 weeks, we are ensured. After that, ART will prevent transmission of HIV through breast milk. Sorry. Case scenario 4, mother has HIV 1 and 2 co-infection. She's on TLD. She has a viral load of 685. What ARV prophylaxis to be prescribed? What ARV prophylaxis to be prescribed? Yes, I'm very happy. So yes, zidovudine twice a day. Nevirapine will not work because she has HIV 1 and 2 co-infection. Low risk for HIV transmission because the viral load is less than 1,000 copies. So zidovudine two twice a day for 6 weeks. Okay. At 6 weeks, what testing will be advised in this baby? Trick question. Ma'am, DBS only detects HIV 1. So DBS will cover the HIV 1 infection. What will we do for HIV 2 infection? So this is that DBS testing for at 6 weeks will only detect the HIV-1 virus. We need to send a brief summary of the mother with SASEP, HIV-2 reference lab, and SACS for guidance for testing of the baby for HIV-2 virus. Just sending DBS is not enough because the mother has got HIV-1 and HIV-2, and HIV-1 and HIV-2 would be could be transmitted to the baby. Your question is that if the PLHA was taking ZLN, TLN, now on TLD, she can still be given nevirapine because it is not single dose nevirapine exposure causes nevirapine resistant strains. The baby, so I'll just go back to my slides about indication of zidovudine. Just revise that. So what is the indication for zidovudine? Infant born to a mother with confirmed HIV 1 or 2 or HIV 1 of HIV 2 infection or HIV 1 and 2. Infants born to mothers who have received single dose of nevirapine during early pregnancies, or infants born to a mother who has PI-based ART regimen due to treatment failure because previously the mother was on a nevirapine-based or an efavirenz-based regimen. So in this scenario, will zidovudine be given? If the mother was taking ZLN, SLN, TLN, is now on TLD, she can be given nevirapine. But if ever you are confused about this, you can always take a SASEP referral, because each situation is different. It is only single dose nevirapine in the past which causes nevirapine resistant strains or drug resistance because of treatment failure to nevirapine and efavirenz in the previous regimen. Anyway, any confusions, it is always written that if you are confused what ARV prophylaxis to the baby, please refer to SASEP and get an answer before before the baby is born. So last case scenario, Mrs. E is asymptomatic postnatal newly detected HIV positive mother who presents to the ART center 3 days after delivery. CD4 is 550 cells. She has opted for replacement feeding, exclusive replacement feeding. Weight is 2.4. So can you tell me what is the management for the mother? So quick answer. You start TLD, link her to the EVTHS program. Don't forget the EVTHS program because the baby has to be followed up in the EVTHS program. Counseling for infant feeding practices, nutritional counseling, safer sex practices. And what is the baby ka management? Let's have some answers in the chat box. Ma'am, not... it is dual prophylaxis. Somebody has written nevirapine. It is dual prophylaxis. So any baby born to a mother who is direct in labor, or any baby born to a mother postnatal within 6 weeks of delivery, it is dual prophylaxis. But for 6 weeks, because the mother has decided that I'll be giving replacement feeding to the baby. If the mother was going to breastfeed, then it will be 12 weeks. If it is replacement feeding, it is 6 weeks. So dual prophylaxis. And the dose of nevirapine is 1 ml once a day, while the dose for syrup zidovudine is 1 ml twice a day, both to be given till 6 weeks of age. No, in formula fed, we do not give it for 12 weeks, sir. It is given only if the mother is on replacement feeding, you give it only for 6 weeks. The reason is that after 6 weeks, that covers the exposure through which is occurred during childbirth. Once the exposure is treated for childbirth, after that, you do not need to give for another 6 weeks because the baby is not being exposed to breast milk. The baby is on formula feed, so it is 6 weeks. Dual prophylaxis for 6 weeks. If you want, I'll go back to that chart, which is there in the guideline, and you will... so exclusive breastfeeding is 12 weeks. Exclusive replacement feeding is 6 weeks. You do not have breastfeed milk, which will give risk to the baby. So why do you need to extend it for another 6 weeks? You just need to cover the HIV risk exposure, which has occurred at childbirth. So these are all my case scenarios. Thank you so much. But we have not finished yet. What is there? We need to prevent unintended pregnancies among these women living with HIV. That lady is going to come back to you for various taking ART. Don't forget, you must guide her about healthy timing and spacing of pregnancy. This is a new concept for us, for our team. It is in chapter 4.3 of the EVTHS guidelines. Please read it. It is very important that appropriate contraceptive methods and planning for pregnancy is very important. And the important thing is that we need to refer them for family planning services. Now, the 3 is that the first pregnancy should be planned only after 20 years of age, after every live birth. Next pregnancy should be planned only after 2 years or later, to keep an ideal spacing of 3 to 5 years. This is very important. You should not forget to tell the lady, now that you have delivered, you must think about healthy timing and spacing of pregnancy and refer her for a contraceptive for contraception at the family planning centers. Okay, and after a miscarriage or abortion, the next pregnancy should be planned only after 6 months or later to avoid chances of abortion again. Now, for anyone who wants to read further, this is a reference module from RMCH plus N. The reference is given there. Remember that pregnancy can occur as early as 4 weeks after delivery or 10 days after abortion. So it's very important that any mother, you call the mother to meet you at 40 days of pregnancy, at 40 days after her delivery, 40 days after her delivery, you need to follow her up. When the baby will be given the first vaccine at 45 days of age, you tell the baby and the mother should come. She will come for her pill pickup, advise her, counsel her about all the various counselings which we have spoken, and if she's breastfeeding, about breastfeeding, safe breastfeeding, but also tell her about family planning methods, because pregnancy can occur as early as 4 weeks after delivery. So this is just a short form. These are available free of cost under the family planning program. There are so many available, and a good gynecologist would be able to advise, but our ART team needs to inform her that contraception is important. You need to plan your next pregnancy after 3 years, and for that you need to decide, discuss, and zero down on what contraception you would be using. Thank you so much. Shweta, any questions? I've covered most of them, but if there are any questions, I'll be
Yes, we have a few
to
in the
answer.
chat box, ma'am. If you can please allow me to share my screen.
Yeah. So I'll stop sharing then.
Yeah.
1 minute.
Right. Hope the screen is visible.
No.
Ma'am,
So
you
the
want me to
first
read them
question
out?
is if ANC, yeah, I can read. So the first question is that if ANC case registers and starts on ART near term, ART coverage, she has received just 3 weeks, her viral load is TND, it will be low risk, because we decide on the risk of the HIV transmission to the baby depending on what mother's viral load is. If the mother is target not detected, then the baby has a low risk for getting HIV, and so a single drug will be given. So don't decide high risk and low risk from the duration of ART. Please, these are new guidelines. These are very scientific guidelines based on the WHO guidelines, that based on the maternal viral load in the last month of pregnancy, we will come to know whether the baby has a high risk or a low risk. So if the mother has target not detected, that is less than 1,000 copies, the baby is low risk for HIV transmission and would be given a single drug. Duration of ART is no longer taken into consideration. We go about from the important thing is the viral load test result of that additional viral load done in the last month of pregnancy. Female taken TLE and LFU. She returns in 25, returns back at 33 weeks, started TLD. Her VL is less than 150. Yes, so less than 150, low risk for HIV transmission, single drug, it will be nevirapine will be given, because you have to just find out whether she was given single dose of nevirapine in the past. So in years ago, in 2012, 2010, pregnant women were not given ART. Pregnant women were started on ART only after 2011. Before that, the uh, pregnant women whose CD4 was less than 350 were started on ART. The rest of them were given a single dose of nevirapine as prophylaxis at the time of delivery, and the baby was given a single dose of prophylaxis. So those mothers who were given single dose of prophylaxis and were not on ART in their previous pregnancies would have developed nevirapine resistant strains. But here the mother was on TLE. Triple drug doesn't cause resistant strains unless she has been documented to have treatment failure. So in this case, low risk for uh, transmission would be nevirapine, single drug, not zidovudine. Zidovudine syrup dosage, I have given the dosage chart, Annex 7 of the EVTHS guidelines. Shweta, you shared that as a handout? please provide us. So I can't provide you with syrup zidovudine, sir. It is the SACS which provides. So it is given. Please see the guidelines. EVTHS guidelines is given very clearly about syrup zidovudine, when it is to be given. And if you are having problems in procurement of this, then it is SACS. So timely inform the SACS that, okay, we have a patient with high risk, with high viral load, the pregnant lady, the baby would need zidovudine, or we have a mother who's HIV positive too, HIV2 positive, the baby would require zidovudine syrup. You'll need to timely inform the SACS in the ICTC that you need zidovudine syrup. So if the mother is not adherent to ART treatment, then what advice? Of course, we would advise to continue to give mother on breastfeeding. Yes, we would. So breastfeeding is not advised based on whether mother is adherent or not. Breastfeeding or feeding options is decided by the parents. The doctor only advises them. So if your mother is not adherent, then you need to have enhanced adherence counseling. So the guidance was that all pregnant women would be given enhanced adherence counseling, and the counseling will be monitored. If they do not come, if they come as a proxy patient, then the CSC will be asked to go and find out and calculate their pill box, see their pill box, whether they are taking drugs or not. So you need to give enhanced adherence counseling to anybody who's not on ART, or who are not taking ART adherently. The thing what you're asking is that what advice about feeding? The feeding options are decided by the parents, not based on what the adherence is. So you have to ensure whether ART adherent mother has to be even before she becomes pregnant. The ART adherence has to be started along with viral suppression in pre-pregnancy period to plan her pregnancy. Any other questions? In formula fed, no, formula, I've already answered about this. Formula fed will be given only 6 weeks, because the extended next 6 weeks are to cover the breast milk. If there's no breast milk in a formula fed baby, the dual prophylaxis is only for 6 weeks. The second, suppose a mother comes postnatally at 6 months. Okay, if the mother comes at 6 months, we do not give prophylaxis immediately. We send the baby to a pediatrician to clinically evaluate the baby. Does the baby have signs of HIV infection? We send DBS to the of the baby for HIV testing. We start the mother on ART, and we start the baby on cotrimoxazole prophylaxis. At 6 months, giving prophylaxis to this baby would be only if the you can consult your SASEP or the pediatrician and you have a consensus. Some pediatricians request that at 6 months, the baby doesn't have any signs of HIV at present, but is exposed to breast feeding. So till the mother becomes virally suppressed, we can give ARV prophylaxis to the baby. But that is not the discretion of the ART medical officer. You will need to take a SASEP referral and ask what should be done in the situation in the baby which has come at 6 months, and what is the evaluation done by the pediatrician. Does the pediatrician, because if the pediatrician says the baby has signs of HIV infection, the baby would be put on ART vis-a-vis ARV prophylaxis. Okay, next is this I've given. Earlier was this I've already answered, Shweta, that the mother will be given single nevirapine, not zidovudine, because it's a triple drug. The indications of zidovudine I had revised for them. If the mother has both HIV 1 and 2, the DBS for HIV 2 is not done. There is no DBS. If you see the dried blood spot test for HIV 1. Okay. So for HIV 2, we need to do Western blot, which is done at the SRL. So SRL or NRL. So the process is that you make a SASEP referral, you make a summary, case summary, you send the DBS for HIV, there is no DBS testing for HIV-2 at present. So for HIV-2 testing, you make a summary, send it to SASEP, SACS, to your SRL, and they will give you an opinion and an appointment for the baby for testing for Western blot. High risk baby mother on PI based regimen, the infant prophylaxis, yes. So in this situation, the drugs nevirapine cannot be given. So zidovudine and lopinavir ritonavir syrup will be given. Lopinavir ritonavir syrup will be started 2 weeks after starting the after birth, because the first 14 days we cannot give syrup, lopinavir ritonavir. And in this situation, take a SASEP opinion or a PCOE opinion, what should be given. And the second thing is that avoid having mothers with HIV-2 or second line, third line pregnant women. Should be adherence should be ensured. You do enhanced adherence counseling to them so that they have suppressed viral load at the time of delivery or in the last trimester, because high risk baby mothers with in second line, third line, ideally raltegravir syrup should be given, but raltegravir syrup is not available. So we can only give lopinavir syrup, start after 2 weeks, and zidovudine we start immediately after birth. So after 18 months, we do not stop. We can stop prophylaxis or continue. Please, who's asked this question, please can unmute and ask. We don't give prophylaxis after 18 months. You're talking about cotrimoxazole? Which prophylaxis? Shweta, who's asked this question? Can just unmute and ask me. This is cotrimoxazole prophylaxis?
No, that's not written, ma'am.
So it can be only after 18 months. So see, cotrimoxazole prophylaxis is continued, started at 6.
Yeah, sir is talking about syrup. So, ma'am.
What is, sir? Just
Syrup,
unmute and ask me the question.
Yeah, Kiran sir, can we please give mic access to ART Haveri, HAVERI? Yeah, thank you.
Yes, sir. Sir, just ask the question.
Can please unmute. ART Haveri, the person who has asked about this question after 18-month baby follow-up.
I think they are talking about cotrimoxazole prophylaxis. So cotrimoxazole prophylaxis is started in the baby at 6 weeks of age and continued till HIV infection is excluded. And the last testing for excluding HIV infection is 3 months after complete cessation of breastfeeding. So if the mother is breastfeeding till 24 months, then 3 months after 24 months, that is at 27 months, you do the testing. After that result comes negative, you stop the cotrimoxazole prophylaxis. We don't stop it at 18 months. That's the old guidance where we used to stop breastfeeding. Now we are saying mother can continue breastfeeding under ART adherence and safer sex practices and advising viral suppression till 24 months, like in general population. So the last test is done 3 months after stopping the breastfeeding. That will be the final testing, and if it comes negative, then the cotrimoxazole prophylaxis will stop. But if the cotrimoxazole, if the baby comes positive, then it will be continued because the baby will be started on ART. I hope that is the question.
Yes, ma'am. Yes, ma'am. He has just sent it in the chat box. Yeah.
Okay. Any more questions?
So no more questions.
Anyone wants to ask?
I have got a question. I am Dr. B.N. Tripathi from Bhubaneswar ART Center, Odisha.
Sir?
First of all, I congratulate you, madam, for the nice presentation. And
Thank you.
Madam, at some place in the slide, I found that in case of virally suppressed mother, the and breastfeeding, and the prophylaxis will continue for 6 months only, in spite of the fact that he's getting...
there is no 6 months. Where is it written 6 months? In my presentation.
In the presentation slide, it was there, and there was a footnote that after 6 weeks, the mother's ART mother's ARV will take care of the subsequent infection.
Yeah, it's not 6 months, it's 6 weeks. Yeah, it's not 6 months. Just show the, I'll share my.
I'm telling you,
I'll
6
just,
weeks, not 6 months, 6 weeks, barely
huh,
6. Even if the
yeah.
baby is breastfeeding, the
So
prophylaxis will
I'll
be
explain
extended.
the concept. So the concept is that why do we stop after 6? So first you understood that the exposure during childbirth is covered by the 6 weeks of ARV prophylaxis, right?
Right?
Okay. Now, if the mother is virally suppressed and she's taking ART, the ART will prevent the risk which happens through breastfeeding if mother is virally suppressed. But
Right.
if the mother is not virally suppressed, then we give another 6 weeks of ARV prophylaxis to cover the breastfeeding exposure, hoping that after next 6 weeks, means 12 weeks of ART, the mother would have achieved viral suppression and the breast milk will be safe under cover of ART. Because ART is also working. Now we told you how ART is working. How ART works, it also gets secreted in the breast milk.
Ma'am, it is understood. But my question is again, if mother's ART is taking care of some infection beyond 6 weeks, if the mother is virally suppressed, then why you give in the first 6 weeks?
Because, sir, because there's been a high risk of exposure during childbirth. During childbirth, the baby has been exposed to blood secretions. He may have swallowed it, it may have entered through the ear, mouth. The baby has had a whole lot of exposure during childbirth. Whether a normal delivery or a cesarean delivery, there is a lot of exposure during childbirth. That is the highest risk of transmission. To cover the risk, the exposure of HIV virus in the secretions and blood during childbirth, we have given all children born to HIV positive mothers ARV prophylaxis.
You mean to say that there is a very high risk during that period?
Depending on the viral load. Depending on the, yes, sir. Yes, the highest risk is.
TND. Madam, even if the mother's
No. Sir, just listen. Depending on the viral load, the exposure becomes high risk or low risk. If the mother is TND, it is low risk. Right. So we just give it for 6 weeks. You're saying don't give it at all, right? That's what you're saying?
Yeah, my question is that only.
No, but the guidance, whatever tests and research has been done and whatever has been given, that exposure is the highest risk. So to cover the highest risk, even though the mother is TND, we need to at least give 6 weeks of ARV prophylaxis. And that's why it's only single drug.
Okay, understood, madam. Thank you.
Okay, thank you. Thank you. Very good question, actually. That means you've heard my talk very sincerely. Thank you so much, sir.
Thank you very much, ma'am.
Okay, thank you. Any more questions?
Ma'am, there's one question in the chat box. Should baby be tested after 6 weeks?
No, so which after 6 weeks where? Who has asked this question can unmute and ask. Baby first testing is done at 6 weeks. The next testing is done at 6 months of age. What 6 weeks are you talking about? I didn't understand.
Anup sir, if you can please unmute.
Shweta, you will need to have a session on EID because all these questions are EID only.
Right, ma'am. I'll speak to Purnima ma'am on this.
6 weeks you're talking about after stopping breastfeeding? That is
Anup
what you're
sir,
asking?
can you please unmute? I think it must be the same. Okay.
So the previous guidelines were that the last testing is done 6 weeks after complete cessation of breastfeeding, but 2021 guidelines overrode this.
Please,
and yes.
Please repeat regarding the follow-up of baby, regarding when to be tested.
For HIV testing.
Yeah,
HIV
yes,
testing. So the first test is done at 6 weeks. The 6
Okay,
weeks
ma'am.
is because the baby will coming for its vaccines, will be coming for the quatrimoxis or prophylaxis. So it is fixed at 6 weeks. Everything will be done that day in 6 weeks.
Okay.
The next testing, if the baby is negative, will be at 6 months. Okay.
Okay, ma'am.
The next
Okay, ma'am.
testing will be at 12 months. Then the
Okay,
next
ma'am.
test will be at 18 months. But if the mother is breastfeeding, we will continue testing. Even if the baby is negative, we'll continue testing till the mother's breastfeeding stops 3 months after the last exposure to breast milk. Like complete cessation, if she stopped breastfeeding at 24 months, then the last testing for HIV infection will be 3 months after that. That is at 27 months. What
Okay,
is your
thank you, ma'am.
question? You're talking about 6 weeks. So these were all guidelines. Now we've aligned it to what the WHO guidelines say is that the last exposure testing should be after breast milk is stopped is 3 months after stopping of breastfeeding.
Yes, ma'am. My question was same only. Like how to be
Yeah,
follow
those
up
were
of
all
the-
guidelines, sir. Those were all guidelines. If you see 2021 guidelines, it is 3 months after complete cessation of breastfeeding is the last HIV testing. And we
Oh,
continue
thank you, ma'am.
quatrimoxazole prophylaxis till the last test comes negative.
Ma'am, thank you so much for facilitating this important session, especially with the revised guidelines.
So thank you so much. And I'm very happy to have such an interactive listeners. Thank you so much for answering the questions and patient listening. I've gone beyond my time given to me. Thank you so
Thank you
much,
for that too,
Shweta.
ma'am. Thank you for your time too.
Thank you.
Yeah, we'll quickly run the feedback form, ma'am. Requesting
Okay.
Kiran sir, if we can have the feedback form, please. Yeah, the feedback poll is now visible on your screen. Requesting participants to please fill in this poll before you leave the meeting. There are 5 questions in all. Scroll through the questions, click on the answer of your choice, and please read the 5th question, that is the last question, carefully. Yeah, the PPTs will be sent by email to all the ART centers.
Shweta also send the Aniksha 7 so that they can have a printout of that, the dosage, because somebody was asking me about the dosage.
Sure, ma'am. We'll do that. We'll wait for another minute. Kiran sir, we can end the e-poll now. Thank you everyone for your active participation and patient listening. We'll conclude the session now. Thank you, ma'am.
Thank you so much.